Welcome. My name is Dr. Stephen Sanet. I'm an American osteopathic physician, and I'd like to speak to you today about cephalgia, head pain, different types of headaches, and the osteopathic perspective and treatment of these. If you like what you see today, please subscribe to our YouTube channel at the Osteopathic College of Ontario. Okay, for me it's morning, so I'll say good morning to everyone here. Thank you for attending. I want to talk to you today about cephalgia. According to the World Health Organization, 50 to 75% of adults between the ages of 18 to 65 years in the world have had a headache in the past year. 30% of headache sufferers have reported migraine headaches, and a headache on 15 or more days every month, which means half of the month, affects 1.7 to 4% of the world's adult population. That's quite a significant number. For those of you who have studied with me, you know this is my number 2 on my list of 5 things that are very common among adult patients. Number 1 is low back pain, and number 2 is cephalgia, and I combine that with neck pain. It's just a very frequent occurrence for us in the musculoskeletal world, in the osteopathic world, in the medical world. So why is it so prevalent? One, let's just look at the regional neurology. The frequency of headaches is probably most likely due to the massive, rich nerve supply and also the psychological implications of having head pain. The nerves responsible for headache, they have their source in myelinated C fibers and A delta fibers. A lot of them are coming from the trigeminal nerve, glossopharyngeal nerve, vagus nerve, roots of C1, 2, and 3. And that's a short list. It's coming from more than just that. Pain-sensitive structures, your eye, your ear, your sinuses, the vascular supply of the cranium, the dural sinuses, periosteum of the skull, cranial muscles, upper cervical muscles, cervical spine. Again, a very long list of very sensitive structures. And just to mention something for a moment about the eye, if you remember from studying the homunculus, 80% of the neurology has to do with your eye. So having anything wrong with your eye at all really increases your perception of how severe that headache may be. Some commonly overlooked etiologies that might not be, strictly speaking, osteopathic, just things that are easily fixable if you can identify it. And that is, people can have headaches because of food allergies, something that they're taking in their daily diet that's causing it. Medicines. OTC here, that's an abbreviation for over the counter. So there's prescribed medicines, and then there's just so many things that even as a physician, we're just not really familiar with that people might be taking. Over the counter medicines, herbs, and things that are not part of the traditional medical education. There's infective reasons to have a headache, viral, bacterial, fungal. There's metabolic reasons. Those of you who are big coffee drinkers that have ever tried to stop drinking coffee, you can get a headache from that withdrawal. Fever, this is another reason for headache. Some important questions to identify what type of headache you may be dealing with. Does that headache feel like your whole head? Is it holocranial, or is it on one side, hemicranial? Is there a specific area that's very painful? How long does the headache last? If a headache is of short duration, there and gone, that really points to one type of headache. If it's there all day, it points to other types of headaches. What brings it on? Is it sudden, or does it just slowly come up on you, which is what we call insidious? Do you have an aura? Do you have a prodrome? Do you know that you're going to get a headache? These are important questions. How often do you have headache attacks? Is there anything that seems to precipitate it, that causes it? What other symptoms might be associated with your headache? Is there any family history? And do you have any allergies? Again, these are important questions to ask. This is not a complete list, but these questions very quickly start to narrow down what you might be dealing with. There's seven, I'm going to give you here seven danger signs for an ominous headache or something that should have you concerned. And that is a first headache. For an adult population, most of us have had a headache because we work hard, we have a lot of responsibilities, we have many things on our mind. It's really strange if an adult patient comes to you and says, I'm having a headache and I've never ever had one before. That's something to be concerned about. A headache due to exertion, someone that is exerting themselves, doing some heavy activity, meaning that they are putting greater demands on their cardiopulmonary system, and that's causing their headache. That may be a reason for something else that needs to be looked at, that may be really wrong. Headache with a fever, this is a bad sign. Headache in a drowsy or confused patient. A patient who, especially a family member, might come in with an older family member saying he or she is having a headache, and they are not like themselves. They're not having their normal mentation. That's a very ominous sign, meaning a very dangerous sign. A headache in a patient who has nuchal rigidity or other meningeal signs, nuchal rigidity being severe tightness on the neck. Headache in a patient with abnormal physical signs. For those of you who are examining people in other types of ways, acupuncturists, Oriental medical docs, MDs, and so forth. Other abnormal physical signs may point to something more ominous. And the last category I have is just a patient who looks ill, and I put that in quotes. And what that means is, by your experience, maybe you know this patient and it doesn't seem like their normal headache. Something just looks wrong with them. I don't ignore that feeling. Very often that feeling are other sensations that are coming into you that are telling you this person needs to be looked at in a deeper way. The reason why I give you those ominous signs is because for those of you who are, depending on the level of your licensure, if you're practicing as a physical therapist or as a massage therapist or as an athletic therapist or other types of professions outside of the Oriental medical doctor world, the MD world, the osteopathic medical doctor world, I'm focusing this lecture on things that are amenable or treatable from an osteopathic perspective. When they have dangerous signs or you feel that these symptoms might be outside your level of licensure, it is critical that you refer this patient out to make sure that they get a proper medical evaluation to rule out any life-threatening things that may be going on. In my own experience, I've never had a patient be upset with me because I sent them to another specialist to have them evaluated, and it turned out to be nothing. I would rather make an error on the side of caution. I would rather say, I'm a little concerned about this. Let me have a neurologist look at you. Let me have someone else look at you. And they come back and say, oh, they said it was nothing. They've never been angry with me for that. So if you ever have doubts in your mind, it's always best to refer. And then if the medical people have cleared them, then you can safely work within your own level of licensure. And you have done what is ethically responsible. So that differential diagnosis, those warning signs, again, this is a short list, but some things that might be going on that you might get a first clue by those signs could be a subarachnoid hemorrhage, epidural hematoma, hypertensive crisis, meningitis, increased intracranial pressure, acute purulent sinusitis, which is not a regular sinusitis. It's not just my sinuses are running. It's something that can lead to an empyema, which is life-threatening. Vasculopathies, AV malformations, space-occupying lesions. I'm not going to go through how you would diagnose or what these all mean. Okay, in the medical world, we have to understand them. In the manipulative world, you don't need to understand them, but you do need to know when something should be looked at by someone else in the healthcare system. So, our differential diagnosis. What are we commonly seeing in the clinic? We're commonly seeing tension headaches, migraine headaches, a mixture of the two. Cluster headaches are much more rare, actually, much more rare. Each of these headaches are amenable or treatable by various osteopathic modalities. It's not a one-size-fits-all treatment. I don't do things as a protocol, meaning, oh, do cranial for this type of headache, do counter strain for that type of headache. It doesn't work that way, not in my experience. Common modalities that are used, this is just a short list of different osteopathic things that you might do, and we can make this list longer. Cranial, visceral, muscle energy, myofascial. You can mobilize them, FPR, lots of things may help to treat that headache. So let's look at migraines. Let's talk about migraines first. Migraines generally have a hereditary component, not always. The etiology is a vascular spasm followed by vasodilation. It is exacerbated during periods of intense nervousness, anxiety, depression, anything psychological that's going on, and that's very likely to superimpose a tension headache. Classic versus common migraines. The classic migraine is that there's a prodrome. There's signs and symptoms before the actual headache's coming on. A patient may know that they are going to have a headache that day. They don't have it now, but they know they're going to have it that day. They may have an aura or sparkles or diplopia and different things in their visual field. They may feel nauseous or actually throw up and vomit. They can have hemisensory disturbances, hemiparesis or paresis. Hemiparesis, paresis, this is very, it's not very common. I've seen it with patients. It's quite significant when that happens. Seizures, or they may become aphasic, difficulty with speech. Again, their mentation may be coming down. Some symptoms that mix with classic and common migraines, they'll describe it as a throbbing type of pain. Location is usually hemicranial, but it can be holocranial as well. Photophobia is common. Phonophobia, meaning they don't want to, light bothers them. They come in with the dark glasses. They don't want to hear any loud noise. Tension headache is often concomitant. It'd be very difficult for you to have pain, have a lot of pain with a migraine headache, and for that not to tighten nearby muscles. And then it becomes a symbiotic problem. You have a tension headache making the migraine headache even worse, or possibly coming in before the migraine headache. Migraines are often aggravated by red wine, nuts, aged cheese, chocolates, caffeine. These are things for them to avoid. Migraine headaches, women are more affected than men statistically. Cluster headaches, these are not so common. They have a disturbed hypothalamic biorhythm. Excess smoking and drinking may precipitate via sphenopalatine irritation. They are usually hemicranial, to one side, and it usually centers around a single eye, and you can see that eyelid is dropping down, or it's called atosis. The trigeminal nerve is theorized to be the source. Also, cervical somatic dysfunction with irritation of the spinal accessory nerve is thought to be a component. So the symptoms for cluster headaches, look very different than the migraine headache. They will describe the pain as excruciating, stabbing pain, not a throbbing, achy pain, but that someone is stabbing them with a knife in their eye. And it's usually on one side, and you can see they will have that itosis, that lid will be lagging down. It will be associated usually with ANS symptoms, autonomic nervous systems. They'll have lacrimation, there'll be tearing, flushed face, nasal congestion, and the conjunctiva will be all red. This affects men more than it does women, and the onset is usually between ages 20 to 40. The attacks they are not all-day attacks. They are severe 30 to 90-minute attacks. And when you observe a patient undergoing one of these attacks, it is very difficult for them even to sit still. It is like they are under attack, very severe. These headaches can disappear. They can have a headache vacation. They can disappear for months with no headache and then come back again. Alcohol precipitates, but only during an active cycle. If they're having a cycle of these headaches appearing, alcohol will precipitate it. But when they're having vacations from their headache, alcohol doesn't seem to precipitate it. There is a high rate of suicide associated with cluster headaches. They are that severe. Tension headaches. This is where we are traditionally see our role in the tension headache. Tension headaches, lots of reason to have tension headaches. There's mechanical reasons, either they have an acute injury or they have an overload of the muscles, or they're doing some chronic repetitive overuse uh, situation causing the muscular abnormalities. So they can have muscular, tendinous, fascial reasons. They can have ligamentous reasons. They can have musculoskeletal reasons or skeletal misalignments causing the muscles to be hypertonic, hypotonic, and so forth. And I will include TMJ, temporomandibular joint dysfunction, in these above categories. I will include it as a muscular origin headache, tension headache. So in muscles that we would consider for this, that again, this is a short list. So I've given you some TMJ muscles: pterygoid, digastric, masseter, um, facial muscles, cervical muscles, splenius capitis, posterior cervical musculature, deep uh, anterior cervical musculature, trapezius, sternocleidomastoid. These are all in the immediate vicinity. But these could also be hyper or hypotonic because of something lower down, okay, in the thorax or in the pelvis, and you're getting this as a secondary response. This is why I like the global approach to finding the osteopathic key lesion. The headache key lesion may not be in the head at all. This, what I've made is just an arbitrary pie chart here to try and describe something. And that is, I think it is very commonly overlooked, the tension headache and its importance. Because I've had great success with all of the headaches I've mentioned before. The most difficult would be the cluster headaches, but I've had good success with cluster headaches. I would say I've had great success with migraine and tension headaches. And I say great success because I see tension component as part of the migraine headache. I may not be able to change the vasodilation and vasoconstriction causing the migraine headache, but I may be able to affect other attributes. So, for example, in this pie chart, what I'm showing is it's just arbitrary. I'm giving what might be someone's migraine headache, and let's say that let's say this part of the migraine headache, 1/3 that headache is because they're having vasodilation. That's what I'm saying. That's what's pathognomonic for migraine headache. We can argue whether the tension headache uh, is prior to the migraine and it set it off, or it's because of the migraine and it's a sequela. But let's say they have migraine headache caused by vasodilation. Now they also have a concomitant um, tension headache. Well, that tension headache is going to cause spasm of muscles. I think you would all agree with me on that. Those muscles that are irritated, they're going to become a little edematous. That's going to increase the amount of painful hormones that are being secreted. These three areas can all be changed directly by our osteopathic manipulation. We can argue about whether or not we're changing this. I would say we can change some of this. Some of traditional medicine people would say we're not changing it, but absolutely, I can change this, I can change this, and I can change this. If I can start to reduce that headache, I can probably affect some of their anxiety. I can probably help their hypothalamic rhythm. They're going to get a little bit better sleep. So I can reduce these two secondarily. Family issues, work issues, other stresses I might not be able to change. So that's the idea of what I'm showing with this pie chart. And this is something that I will describe to patients. I don't spend too much time trying to explain the osteopathy to patients, but if they ask how is it that we're able to help, and a traditional medical practitioner said, "Oh, absolutely, you cannot help them," I would explain things that are very understandable about muscle tension, spasm, and so forth that is very changeable. So let's look at painful points of muscular and ligamentous origin. Painful points on soft tissue in the musculoskeletal world, not just the osteopathic world. We commonly look at things that we call trigger points, tender points. In the osteopathic world, we also call them Jones points, and Chapman's reflexes. And each of these may be treatable, very treatable by osteopathic modalities. So let's look at them. The trigger point, this is from the work Simmons and Travell. This has had actually many other names throughout history, what a trigger point is. may or may not have a palpable mass. It has some hyperirritable locus within that muscle, and if you push on it or compress it, it causes a referral pain pattern somewhere. And that pain pattern may be associated with autonomic phenomena. The types of trigger points that we might see are active trigger points, latent, and associated trigger points. An active trigger point means, in this example taken from Travell and Simmons, there's a point here and it's causing a radiation pattern of pain that may be in any of these areas. The densely colored area is showing the more common areas. What they're showing here is a point that's causing pain here that starts here and radiates to another area. So that's an active point. It's actively causing that problem. A latent point is something that's clinically quiescent, meaning it's not doing anything until you irritate it. An associated satellite or secondary point is something that's caused by overload from a trigger point somewhere else, secondary to that other point. Tender points, or what we learned in the osteopathic world as Jones tender points. It is a common osteopathic perspective that a Jones point is a tender point without a pattern of radiation, and that's what differentiates it from the trigger point. From my perspective, just Dr. Sanet's opinion, I think it's arguable that a severe tender point is actually radiating out locally, and therefore I think the difference between a tender point and a trigger point may only be semantic. It just may be that we're giving it different words, but they may not actually be different if it's radiating out in a concentric fashion. Chapman's reflexes. Frank Chapman described points that he found as a ganglioniform contraction. It is not a ganglia, it's not confused with a group of nerve cells. These points may or may not be tender to palpation. What made them different was these points were mapped out anteriorly and posteriorly, and they correlated to a visceral disease, an underlying visceral disease. So that overview of trigger points, tender points, Chapman's points, to put it in a clinical perspective, let's say a Chapman's point is reflecting something that's going on in the viscera that causes increased stimulation back to the cord, or facilitation, we would call it, and it's coming back out as a viscerosomatic reflex, as a Chapman's point somewhere. We can take the same idea and say about an overloaded myofascial structure as a trigger point or as a Jones tender point, either one, and say that it's coming out as a myofascial point of radiation or another point associated with Dr. Jones' tender point theory. So treatment-wise, we have many different modalities to treat this in the osteopathic perspective for trigger points, tender points, Chapman's reflexes, without necessarily diagnosing which that point is. There's some simple treatments we can do. There's more advanced treatments we can do. In a more advanced perspective, it is looking for that key lesion, in my opinion. Others may have different opinions, finding out what the underlying cause of that headache is. Or in the case of migraine headaches, doing what you can do cranially to try and reduce the vascular aspect, and also doing myofascial therapies to reduce the very likely concomitant tension headache. What I'd like to do now, before we go to questions, is just make a statement that if you've enjoyed what we've done here, please subscribe to our YouTube channel. This same lecture will appear on the YouTube channel.